12.
Mm-hmm.
A 37-year-old, sorry, a 37-year-old woman gravid to para 1, 10 weeks of gestation, comes to the physician for her first prenatal visit. 7 years ago, she underwent cone biopsy of the cervix for cervical cancer. 4 years ago, her first pregnancy ended in preterm delivery at 20 weeks of gestation, following 3-hour history of strong, painless pelvic pressure and vaginal bleeding. The newborn died after delivery. Pelvic examination today show no abnormal. Ultrasonography shows fetus consistent with 10 weeks of gestation. Cervical length is 4 centimeter and low anterior placenta. The patient is greatest risk of which of the following condition?
Ready?
Yes,
Okay. So it is cervical insufficiency. The American College of OBGYN defines cervical insufficiency as the inability of the cervix to contain the pregnancy without the presence of contractions, labor, or both, typically during the second or early third trimester. The condition is associated with miscarriage, preterm or pre-labor rupture of membrane, and preterm birth. Risk factors include cervical trauma from prior delivery or surgical manipulation, such as cone biopsy. Classically, when symptomatic, it presents with feelings of fullness in the lower pelvis, in the absence of contractions of labor, similar to this patient last pregnancy. Speculum exam may show dilated and effaced cervix or protrusion of the pregnancy through the cervical hole into the vagina. Mild cases without dilation of the sternal os may go undetected. Cervical length measurement may show a short cervix with a cervical length that is less than 15 to 25. So the normal is 15 to 25. Treatment is indicated if the degree of cervical insufficiency is significant enough to threaten the pregnancy and in cases of previous cervical insufficiency. This is accomplished through cervical cerclage, which is the placement of a suture. We know that, whatever. The suture is then removed at the time of labor or around like 36 to 38 weeks of gestation. It is not DNA. Cervical stenosis is induced by any inflammatory scarring process and presents with dysmenorrhea and or cervical cyclic pelvic pain associated with live flow during menses. If it involves the uterine cavity, it may also cause amenorrhea, infertility, and recurrent pregnancy loss. Given this patient previous pregnancy loss with associated pelvic pressure but lack of uterine contraction, as well as history of convulsive cervical insufficiency is the answer. Placenta previa present with painless vaginal bleeding during third trimester due to placenta that partially or completely closed overlies the cervical os. Risk factors for its development include causes of uterine scarring such as multiparity, prior C-section, prior dilation, and choletta. It often necessitates C-section to prevent fetal-maternal hemorrhage. This patient has low-lying placenta, but no evidence of placenta previa on ultrasound. Okay.
a
Mhm.
27-year-old a 27-year-old newly gravid woman comes to the physician for a follow-up examination after a recent pap smear showed a low-grade squamous intraepithelial lesion. She feels well. She has no history of sexual transmitted illness or serious illness. Mens occur at regular 30-day interval. Her last menstrual period ended 4 weeks ago. Physical examination and pelvic examination shows no abnormality. Colposcopic examination shows punctuation. Colposcopic examination shows punctuation and mosaic pattern. Punctuation and mosaic pattern on the squamocolumnar junction cannot be visualized. A biopsy specimen of the cervix shows CIN3. Which of the following is the next step?
Hmm. Ready?
Yes.
Ugh, come biopsy of the cervix. So CIN3 is a high-grade cervical lesion with an increased risk for progression to cancer. Cervical cancer is classically associated with infection with HPV high strength. Risk factors include multiple sexual partners, smoking, immunosuppression. Screening pap smear are recommended every 3 years. We already know women 21 to 29, 5 years with HPV for testing in women 30 to 65. Abnormal pap cytology results are evaluated by colposcopy, which allows for visual assessment and biopsy of the lesion. Colposcopy is deemed inadequate if the entire squamous junction or transformation is not visible, as there is a possibility of undiagnosed cancer. In this patient, the biopsy confirms CIN3, which requires excision via cone biopsy of the cervix or a lip. The cone biopsy serves to further evaluate the larger region of the cervix for cervical cancer and may be curative if a margin of normal cervical tissue is identified on histology. It is not Hysterectomy is a potential treatment option for CIN2 and 3 as well as cancer. However, it is important initially to fully evaluate the entirety of the cervical transformation zone via cone biopsy of the cervix prior to proceeding to hysterectomy.
Okay.
Ah, yeah.
A previously healthy 32-year-old woman. A previously healthy 32-year-old woman comes to the physician because of heavy menstrual period 1 week ago. She says that was 1 week her menstrual period was 1 week late. She had a vaginal spotting 2 days prior to onset. Mens typically occur at regular 28 to 29 days of interval, lasts for 4 days. She is sexually active. She and her partner use spermicidal foam and condoms for contraception. She takes no medication. Pelvic examination shows normal uterus. There is no adnexal masses. Which of the following is the most appropriate step in the management?
Ready?
Yes.
This measurement of serum beta hCG concentration. Measurement of serum beta hCG concentration is the most appropriate next step for a patient of reproductive age who presents with abnormal vaginal bleeding. Pregnancy is suspected when there is miss or delayed menstrual period. Live vaginal bleeding can occur early in pregnancy, often due to implantation of the embryo, which can be occasionally mistaken for menses. Other symptoms of early pregnancy include nausea, breast tenderness, fatigue, physical examination, and large globular uterus. But formal diagnosis, you need urine or serum beta hCG. Beta hCG produced by placenta is not detectable in non-pregnant women and doubles every 2 days during early normal pregnancy. Normal pregnancy and intrauterine gestation of sac should be seen at 5-week gestation. Additionally, transvaginal ultrasound provides sufficient sensitivity to detect intrauterine pregnancy. Once beta hCG um, it exceeds like 1,000 to 2,000, whatever. It is not measurement of FSH can be used to evaluate for menopause and premature ovarian insufficiency, as it will be increased in these syndromes. These most often present with irregular menstruation, amenorrhea, hot flashes, blah, 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 and ovulation and low estrogen take. This patient has had regular menstruation up until the most recent, and thus pregnancy is the most likely diagnosis. Not hysteroscopy is used to evaluate the uterus is used to evaluate the uterus for structural causes of irregular menses, as it allows complete visualization of the endometrium. However, this patient has previously had regular menses, making structural abnormality unlikely. And hysteroscopy should not be done until pregnancy is ruled out. Okay, next.
A 57-year old woman gravid to para 2 comes to the physician because of 6-month history of worsening incontinence. 10 years ago she had leaking 10 years ago she had leaking urine only with laughing and jogging. Now she has now she only has urine leakage when rising from sitting position. She says she says this is interfering her usual activities. She has to wear absorbent pad all the time. She takes amitriptyline for migraine prophylaxis. Vital signs are normal. Physical examination normal appearing cervix but decreased rugation and the vaginal mucosa urethra appears normal. On Valsalva maneuver, the anterior vagina walls bulges inferiorly. Which of the following is the most likely diagnosis? Is it due to postmenopausal?
Don't think so.
Detrusor overactivity is urge incontinence.
The key is
But
the Valsalva maneuver.
so it is stress incontinence, isn't it?
Uh, where do you see stress incontinence?
If
User
urine
compliance.
leak out on rising like Valsalva maneuver, then isn't it stress incontinence?
But it's not an option here. What do you see? Oh, you mean inadequate urethral support? No, I don't think it's that. But that's what she had before, but then it has evolved on something else. Mm, Compared to user compliance. Maybe inadequate urethral support. But what is the bulging?
Bulging is like cystocele. Anterior vagina, anterior vaginal wall bulges.
Yeah,
In front of
yeah,
the anterior vagina there is bladder, and behind the vagina there is rectum. So
but can stress incontinence cause cystocele?
can yes can
Okay.
cause.
Yeah, okay. Okay, then it's that then. Okay, ready?
Yes, is it
Okay.
right?
Oh, let me see. Yeah, you're right. Yep. Yeah, it's there. Stress urinary incontinence is common in multiparous women and in men following prostate surgery due to weakness of the muscles and connective tissue of the pelvic floor. Multiparous women, this is typically secondary to pregnancy, with resultant mechanical stress on the vaginal wall and pelvic floor. This weakness of the pelvic floor in turn compromises the support of pelvic structures. Weakness support, including the uterus, bladder, urethra, rectum. Increased abdominal pressure, coughing, sneezing, laughing, heavy lifting causes the vesicourethral junction to move out of its normal position, preventing sphincter closure and resulting in subsequent leakage of urine. It is commonly associated with urethral hypermobility, as evidenced by deviation greater than 30 degrees from the horizontal of an inserted cotton tip applicator with straining. It is often associated with urethrostomy, where the urethra prolapses into the anterior vaginal wall, as found in this patient. But they would say the urethra appears normal anyway, or out of the urethral opening itself due to the loss of proximal support. Stress incontinence can also be associated with cystocele, which also presents as a bulge in the anterior vaginal wall. The urethral permeability is typically absent. Regardless of the cause, the treatment of stress incontinence include pelvic floor exercise, weight loss with the potential need of pessary, device placement, and surgical correction. Okay, next.
Yes. A healthy 20 a healthy 19-year-old woman comes to the physician for advice regarding contraception. She plans on becoming sexually active for the first time with her partner soon. Menarche was at age 13 years. Mens occur at regular 28 days of interval. She does not smoke cigarettes. She is 5 feet 5 inch tall. Weight is 54 kg. BMI 20. Her blood pressure is 110 by 68. Physical examination shows no abnormality. She declines a speculum on normal pelvic examination. In addition to providing the patient with in addition to providing patient with condoms, which of the following is the most appropriate next step in the management?
Ready?
Yes.
Prescribe OCP for 3 months and schedule follow-up exam. Many methods of contraception exist, including temporary and permanent options, hormonal and non-hormonal devices, oral medication, injections, implants, and ovulation tracking. The most appropriate contraceptive method is dependent on the patient and the goals of care. Counseling regarding contraceptive options should determine if the patient wants long-term or temporary contraception, whether they are able to be compliant with the medication every day, menstrual history, and any comorbidities that make some options contraindicated. OCPs are a temporary form of birth control that must be taken every day. They commonly include combinations of estrogen and progesterone, although progesterone-only options are available. OCPs work to prevent pregnancy by thickening the cervical mucus, thinning the endometrial lining, and decreasing ovulation. They are an effective method of contraception when taken as prescribed. A speculum and pelvic exam are not required prior to prescribing OCPs. However, they should be started after the patient turns 21 and in accordance to the USPSTF, whatever. Okay, so you need the pelvic exam when the patient turns 21. Okay. It is not, where is it? Provide the patient information on pelvic exam is less important than prescribing OCP to prevent unintended pregnancy. While the patient should undergo pelvic exam in the future to screen for cervical cancer, it is not necessary to complete the exam prior to prescribing OCPs. Okay, I think that's it.
Next. A previously healthy 24-year-old woman, gravida 1, para 1, comes to the physician to her history of sudden onset severe pain, numbness, and stiffness in her right leg. 3 weeks ago, she delivered a healthy newborn at term after an uncomplicated pregnancy. Her temperature is 37, pulse is 70 per minute, regular respiration is 14 per minute. Blood pressure 110 by 70, lungs are clear, cross condition S1 is normal, S2 is split and fixed. A grade 2 hollow systolic murmur is heart based at the left sternal border. Pulses are absent in the distal lower extremity. Pulses are absent on distal right extremity. The right femoral pulse The right femoral pulse and pulses in the left lower extremity are normal. The right lower extremity is and pale, cold, and tender with decreased sensation to the touch. Movement of affected extremity is limited due to pain. Duplex ultrasonograph show thrombi in the left superficial femoral and popliteal veins and an embolus at the right femoral bifurcation. IV heparin therapy is begun. In addition to right femoral embolectomy, which of the following is the most appropriate next step in the management?
Ready?
Yes.
Okay, so it's echo. This patient has signs and symptoms of acute limb ischemia, which is characterized by pallor, pain, pallor, poikilothermia, pulselessness, paresthesia, and paralysis. Jeez. So the P's. Arterial thromboembolism is a common cause of acute. Wait. So he has arterial, not venous. A common cause of acute upper extremity limb ischemia, typically from a cardiogenic source such as AFib, valvular heart disease, left ventricular aneurysm or hypokinesis, left atrial myxoma, or infecting endocarditis. In this patient, the presence of venous thrombi raises concern for an intracardiac or intrapulmonary shunt. Oh, that has allowed the passage of a paradoxical embolism from the venous circulation to the systemic circulation, bypassing the lungs. Oh, makes sense. Paradoxical emboli may traverse through a pattern foramen valley or ASD, ventricular septal defect, or pulmonary arteriovenous malformation. A split fixed S2 is ASD. Yeah. Patients are at risk for stroke, acute limb ischemia, thromboembolic injury to organs, mesenteric ischemia. Transesophageal cardio echo is the best step to confirm the diagnosis. A bubble study in which agitated saline is introduced into the venous system and time until it's visualized in the left side of the heart can help distinguish between intracardiac and intrapulmonary shunting. Makes sense.
Okay.
Mhm.
So it is acute limb ischemia.
Yes, because I was like, he has the thrombosis in the vein, but it sounds like it's an artery issue. So what is happening? But yeah, it's like the thrombi went from the veins to the artery. That's what they were trying to convey here. Yeah. Okay, next.
A 27-year-old a 27-year-old primary gravid woman, 10 weeks of gestation, comes for her first prenatal visit. He has a history of multiple sexual transmitted disease, IV drug use. Examination shows no abnormality. HIV testing is recommended, but patient refuses. Which of the following is the most appropriate course of action?
Oh, I don't know. Ready?
Okay.
Okay. So it is repeat recommendation of HIV testing in 6 weeks. The USPFT, whatever, and the CDC recommend that everyone between the ages, between the teenage years and 65 years be tested for HIV at least once. Those at higher risk should be screened more frequently. Additionally, as HIV may be transmitted from a mother to a child during pregnancy, and delivery and breastfeeding. Screening for the infection is also recommended at least once during pregnancy. If the initial test is negative, a repeat test is recommended in the third trimester for those at high risk infection. Transmission to the fetus is uncommon if the mom is taking antiretroviral therapy and has a low HIV viral load. This patient is declining HIV testing despite being at high risk. A healthcare provider should evaluate her reasons for declining the test and continue to provide support for her developing pregnancy. After forming a therapeutic alliance with the patient, she may be more responsive to repeat recommendations, to a repeat recommendation of HIV testing in 6 weeks, because the highest risk of transmission of the fetus to the fetus is during delivery of postpartum breastfeeding. Prenatal diagnosis is still of benefit to the patient and the fetus. It is not offered prophylactic antibiotic. Ah, Prophylactic zidofudine therapy is inappropriate for this patient. Zidofudine is most commonly used to treat active HIV infection in combination with other agents or IV during labor and delivery to prevent fetal transmission. However, it's unclear if this patient has HIV and thus treatment is not needed, as adverse effects of zidovudine are significant and include cytopenias, liver injury. It has a lot of adverse effects, basically. Okay, next.
A 19-year-old woman comes to the physician because of 3-day history of urinary urgency and frequency and pain with urination. She has not had fever, chills, flank pain. She has no history of serious illness. Mens occurs at regular 30-day interval. Her last menstrual period was 19 days ago. She is sexually active with one male partner and uses oral contraceptives. Vital signs are within normal limit. Pelvic examination show mucopurulent discharge on the cervix. There is no vaginal discharge. Bimanual examination shows a normal sized uterus and no adnexal mass. Microscopic examination of the urine sample shows 1 to 2 RBC, numerous WBC, no bacteria. Which of the following is the most appropriate pharmacotherapy?
Mucopurulent discharge on the cervix. No vaginal discharge. Pain with urination. It's like a UTI. Hmm. No
Oh,
bacteria.
okay. He has UTI, isn't it?
It has a UTI, but
He has
not
after UTI, he should get the treatment, isn't it?
okay.
And then the normal flora flares up. Is it possible?
What? I don't understand what you're saying.
Like
He has he has a UTI, but none of these are like UTI. This is herpes. This is uh,
acyclovir, like STI.
yeah. This is all of these are kind of STI. Well, it is HIV, but all of these are kind of STI. Acyclovir, herpes, doxycycline,
Is it
chlamydia.
is it chlamydia is possible?
Yeah, but I guess no bacteria. Yeah. Maybe chlamydia. Yeah. I don't know if chlamydia comes with dysuria, with painful urination. Okay, let's
Chlamydia
move.
can cause PID.
This is not PID because there is no antenatal max. There is
Mass
no, yeah.
adnexal tenderness, yes.
But chlamydia, I think it can cause dysuria too, right? Like painful urination. I'm not sure.
Probably, yes. I think so.
Yeah, it's not metronidazole because that, yeah, I don't think it's metronidazole. Okay, let's see. And you're right, it's chlamydia. A patient with symptoms of urethritis, urinary frequency urgency disorder, and
Is
urinalysis.
COVID is rising in your country?
I read that
Like
somewhere in.
COVID Omicron is rising in our country. It is rising as because uh, in India it is rising. Uh,
But it's like here I've seen it online, but I don't see anybody wearing like how COVID was last time, like it was
yes,
over
yes.
the news, but it's not like
L-
that. Like I
Okay.
haven't seen it.
So
So
it
I
is
don't know.
not a like if somebody happens like if infectious disease happens, you got the red alert like in your
Yeah,
country. Yes.
yeah, but we haven't gotten. But I've seen online people are saying like in the state of Florida, it's like, oh my God, they're COVID rate. But I don't see anything like red alert, like everybody wear your mask is what they wear I
Oh,
don't see anything like
okay.
last time. So I don't know if it's true or not. But now that I didn't know if it was true or not when I read it. But now that you're saying it, I guess yeah, it must be
No,
true.
it becomes an issue in our country. That's why I am asking you, is this happening in your country too? Because there are lots of information in whole world spreading from the US.
Oh no, it hasn't.
True, you don't know?
No, it's true, but that's what I'm saying. We haven't. It's not that bad yet here. Yet, I don't
Like
know.
in our country, people start scaring when Trump become. If Trump
Yeah,
says that it is like it is a red alert, like
but I
our
don't
country
think
is
it's
like
gonna
that.
be. I don't think even if it becomes like really bad, I don't think it's gonna be like last time because last time it was like the
Lock,
Democrats that
like lock,
yeah
everything is
yeah
locked.
it was Democrats, so they care about the health and they were like everybody wear protect. But this time it's Republicans and
Don't talk
they
about the Democrat.
yeah.
The president got
So,
prostate cancer with Glacier score 9.
yeah, I know this has scored 9. Can you believe it that he said that?
He's
Can you believe?
crazy, I think.
Like, can you believe that he repeat that?
He do not. Is it possible if somebody has prostate cancer? Is it possible that he do not get any clue? I am very astonished when I see this.
No, I feel like he probably knew, but you don't. I mean, why would you? He was trying to run for president again. So you're not gonna put, I have prostate cancer. I'm running for president. Who's gonna vote for you? Like they're gonna
Oh
feel like
yes, that
yeah,
yes, that's the
it's
thing.
not like
That may be right. That's why he hasn't
yeah,
said anything.
yeah. But now he's already like, okay, he's not running anymore. Because so
He is
it's like
almost in the deathbed.
yeah, no, don't say that. That's mean.
No, no.
But
If you can't do anything, the radiation,
I
you
don't
can't do
know.
anything. It's like just like hospice care.
No,
Like
but he said he can. He said he cannot do surgery, but he can do like I think he said chemo radiation. I don't remember, but he said he
re-
cannot do surgery anymore.
yes, he lost the chance of surgery. Now, if he start getting giving radiation, he is unable to tolerate because he is very sick. Radiation and chemotherapy, you need fitness to give that. You got my point. The
Yeah.
surgery is quite easy. Like you have something happen, you do surgery. It's a 1 day shot. But
Mhm.
for chemo and radiotherapy to give, you need to have good health. But he is already in the
Oh
okay.
my God, you
Truly,
are such. You're like no, I don't want to have you as my doctor because you're like too real. You cannot say that to
like I don't talk. I can't
like
talk emotionally. Like
yeah, you don't
what you
do
have
that.
happened. If you
Yeah.
don't know it, you can't decide.
Yeah, you don't sugarcoat, but you cannot just say it like that. You have to give like a little. I don't know. I feel like
In my med school too, I have done this, and and people actually hate me because of my this issue. But I think that
like
everybody has the right to know what is right, and
yeah,
because
yeah.
not everyone is from the med school, so he do not understand the importance of the time, importance of the taking decision now. You got my
But what
point.
if he comes? What if he comes to you and he's like, yeah, he understands you, explain all that, and he understands it. He says, doctor, I feel like I can still make it. I still have a long way to live. I want to try radiation. I know I can get better. Or are you still gonna say like, no, you are pretty old, so this is not gonna
No, it, it is better to die in the bed than to die under radiation. I am like that.
work? Oh my god.
You true.
But Omar, it's not up to you. It's up to the patient.
Yes,
What is the
I know. I know it is up to the patient, but I am just like that. Okay, leave it because I have seen lots of devastating scenario in my med school. Like
Mhm,
you just 1 minute. Like I found a lady who came with a breast cancer. His
mhm,
TNM. He at that time when she came, his
mhm.
she is just T1, no N, no M. Like
Okay.
then what? Sorry, T not T1. She may be on T2 or 3, but there is
Okay.
no nodal involvement, no metastasis.
Okay.
So her
Okay.
TNM score is very good. But
Okay.
then our surgeon actually told to do surgery, but she
Okay.
refused, and she went to the homeopathic treatment in our country, homeopathic
Oh
treatment,
God.
and she got plenty of steroid. And then
Oh,
after six
please.
months, she came with T4,
Oh,
N1, and M1. Then what
oh.
you there now? What you can do? You can do nothing.
You can do, yeah.
You can do surgery. You can just ease her pain.
Now just the surgery, and since it's metastasized, like what, chemo?
Yes, and now you have to do the surgery,
Mm-hmm.
radiation, chemotherapy, even
Mm-hmm.
immunotherapy. She is poor,
Mm-hmm.
so she is unable to give immunotherapy. She can
Oh,
do surgery only. So now she lost everything.
oh.
If this bad counseling is done before, if you made that patient panic at that time, she may take different
Oh, so
decision.
that's how you see it. That's how, I mean, yeah, I guess
In
that's
our country, it is not like that. In our
yeah.
country, if you can manipulate patient, you can do everything. So I am very bad at it.
Please don't do it here. They'll sue you.
I know that. I know that. I'm just asking. I'm just telling you.
Oh my God. But yeah, no, that like the Biden, he came out saying that he's gonna beat it, and he's optimistic. He can do it. He can.
I
So
don't. I actually hate this kind of
oh my
words.
God. Oh,
Like this kind of words is this kind of word should be kept for the poets, for the
oh
nobelists,
no.
not for the doctors.
Oh, oh no. Ah, okay.
If you put if you got chance, inshallah, if you got chance, just when you are dealing with the patient, put some emotion on that, then you will see the change. Like sometimes people made wrong decision, and you know this is right. So I am not telling you to manipulate. I am telling you to see. I am telling you to make her understand that
Mm-hmm.
what your intention is.
Yeah. Okay.
It's not like a job, like a 9 to 5 job, and you are doing for fun.
That's true.
Okay, lots
Okay.
of emotional talks. Okay,
Emotional talks. No, this is ethics. It's good for ethics. You
but
know.
this kind of ethics, if you think like that, all the question will be wrong.
They'll be wrong. Yeah, please don't think like that during the exam. Don't,
Yes, it
don't.
should be reversed. Okay,
Yeah. A
a 60
patient. Oh wait, I didn't. Did I read the thing? Did I read that one?
nine.
No.
Okay,
Read the
okay.
expedition. Patient with symptoms of urethritis, frequency urgency dysuria, and urinalysis with no evidence of UTI. raises concern for other causes of urethritis, such as STI. Secondary to chlamydia and Neisseria, both organisms can cause signs, symptoms of urethritis. Oh, okay. If left untreated, can progress to cervicitis, PID, to ovarian abscess. In UTI, urinalysis typically shows the presence of white blood cells bacteria, positive leukocytes threat on nitrites, all of which are absent in this patient. Chlamydia is an obligate intracellular pathogen, does not appear on urinalysis or gram stain, resulting in absence of visualized bacteria on urinalysis. Diagnosing chlamydia involves urethral culture and on NAT to evaluate for presence of chlamydia. Treatment consists of azithromycin, doxycycline, combination with ceftriaxone for Neisseria. Wait, it's not acyclovir used in treatment of herpes caused by HSV1. Genital herpes presents with multiple small painful vesicles that erode to cause shallow round ulcers. It may be associated with fever, inguinal lymphadenopathy, as well as dysuria. However, it does not cause mucopurulent discharge. That's the key. Okay, next.
A 65-year-old woman comes to the office because she has had increasing abdominal GERD for past 6 months. Pelvic examination shows 20 centimeter mass filling the pelvis. The mass is cystic to palpation. Ultrasonography shows 23 centimeter cystic mass with a multiloculated cyst that appears to involve the left ovary. Which of the following is the most likely cause of this patient's finding?
Hmm.
Okay.
I know it's ovarian tumor, but endometrioid origin. That makes sense. Epithelial origin, multiloculated cells, stromal, maybe.
Which
Okay.
one you picked?
I don't know. I pick stromal, but I know it's ovarian tumor, but I
You,
don't know.
if you know that ovarian tumor, there is a tumor called EOA,
E O E O Y.
epithelial ovarian tumor.
Uh huh.
So,
But why is it epithelial? You just knew it was epithelial.
okay,
Okay. Okay, let me see. Okay, I'll read why is it why is it epithelial. Okay, so it's ovarian tumor of epithelial origin. Okay. Ovarian cancer commonly presents indolently with abdominal distension, early satiety, weight loss in postmenopausal women. Okay, that we know. Signs and symptoms of advanced disease may also include bowel obstruction with consequent nausea and vomiting, ascites, pleural effusion, venous thromboembolism. In addition to this, physical exam may show palpable nasal mass on bimanual exam and lymphadenopathy. Ultrasound is recommended to identify and characterize the responsible lesion, with concerning features including septation, cystic components, increased blood flow, and heterogeneous structure. Further evaluation is then completed with tumor markers, commonly CA-125, and additional imaging to determine the extent of the disease. Biopsy may be taken of mental and lymph node metastasis prior to definite surgical treatment. With most ovarian cancers being epithelial origin. Okay. These factors for the development of ovarian cancer include family history, BRCA, increased age, smoking, nulliparity, and endometriosis, pelvic radiation, treatment, surgical removal, and chemo. It is not BCD. Ovarian tumor of endometrioid origin refers to uncommon subtype of ovarian epithelial cancer that is associated with endometriosis. Okay. Endometriosis is caused by ectopic, yeah, we know that. Dysmenorrhea, dyspareunia, and dyschezia are classic symptoms of endometriosis. This patient has no symptom of endometriosis, and the subtype of ovarian cancer is much less common. Okay. It's not ovarian tumor of germ cell origin, includes teratomas, trichominomas, tumor, mixed germ cell tumors. Broadly, they present with abdominal pain, vaginal bleeding, and bloating, and what else? As well as increased concentration of hormones such as beta hCG, alpha fetoke, and unilateral pelvic mass or physical result. They are not associated with large cystic masses. And it's not ovarian tumor of stromal origin, includes sex-core stromal tumor, such as granulosa cell tumors, Thika lutein cyst tumor, and Sertoli lady sex. These tumors are hormonally active and commonly present with palpable at nasal mass, abnormal uterine bleeding, especially in the case of yeah, or evidence of hyperandrogenism. They will be unlikely to cause just mass effect. Okay, okay, I get it. Next.
A 37-year-old woman with 15-year history of endometriosis comes to the physician to request information about undergoing total abdominal hysterectomy and bilateral salpingophorectomy. She continues to have severe pelvic pain despite treatment with various pain medications. Her mother has type 2 diabetes mellitus and her father has prostate cancer. She read that removal of her uterus and ovaries will help her to help control her pain. She says that she does not expect to have children because she has been unable to conceive for last 8 years, undergoing extensive treatment for infertility during the next 10 years. Which of the following is the greatest risk?
Mm, got it. Ready?
Yes.
With osteoporosis, menopause is caused by lack of. I read now here. Menopause is caused by lack of ovarian estrogen production. On average, it begins at 50 years old due to a diminution of ovarian reserve, but can occur earlier. Premature ovarian failure caused by chemo or radiation therapy, or by surgical removal of the ovaries. Manifestation include vaginal atrophy or dryness, hot flashes, night sweat, loss of libido, and disturbances in mood or sleeping patterns. Because sex hormones such as estrogen stimulate osteoblasts and increase and maintain bone mineral density. The loss of estrogen leads to accelerated bone loss after menopause, increasing the risk for developing osteopenia, osteoporosis. The condition is often asymptomatic until a traumatic injury results in a fracture, most commonly involving the hip, distal radius of vertebra. The diagnosis of osteoporosis is made using DEXA scan once the bone mineral density falls below 2.5 standard deviation of the mean in a young adult. Symptoms of menopause can be treated with SSRIs, SNRIs, or hormone replacement therapy with supplemental estrogen seen manifestation and sequelae secondary to estrogen deficiency. The duration of estrogen supplementation should generally be limited to 3 to 5 years, as prolonged exposure to unopposed estrogen can increase the risk of endometrial cancer, cardiovascular disease, and mortality, thromboembolism, and breast cancer. Yeah, that's it.
Okay.
Mhm.
A 37-year-old primary gravid woman, 28 weeks of gestation, comes to the office for a routine prenatal visit. Amniocentesis for fetal karyotype at 16 weeks of gestation showed no abnormality. She received raw immunoglobulin intramuscularly. Vital signs are within normal limit. Physical examination shows no abnormality. Her blood group is B negative. The fetal heart rate is 148 per minute. Which of the following is the most appropriate next to prevent RH sensitization in this patient? Prevent next.
16. When do
Women
you
at
give the
20 weeks of gestation.
is
I'm listening to
when do you give it? At 28 weeks or is it 36, 30? Forgot. 16 weeks it was give. I know you give it intrapartum also. I mean after the baby's born, but do you give it? Ah, I feel like it's not. You give it only when the baby is gonna born. Ah, Omar, help me.
sorry.
I know there is some kind of screening at for RHD. Is it 28 to
Yeah, in RA, like raw immunoglobulin, it is also given in 28 weeks, isn't it?
28? I think so. Okay, so it's given at 28. Okay, okay,
These things
ready.
are very confusing.
They are confusing because you know the
Lots of
date.
lots of questions comes
Yeah,
here and there
so
regarding
you need
this,
to
and
know.
we need to
Yeah,
be master in this. Like we need
yeah,
to
because
know the all the forms of this question.
because it's like you know the days. I know the 24 to 28, but sometimes I forget if it's the screening or if it's the vaccine or if it's the the RH the Rogan that you give at that point, or if it's just screening, you just screen. That's the my
And
what I
there is
get.
another type of question where there is like KB test is done, clo- Betke tests.
Oh yeah, yeah. But that one is usually like they will tell you they want to know how much of Rogan they should give to the mom.
So it
That's
is
usually.
when. My question is when. You got my point. Okay, how much rogam, like how much rogam we, how much rogam is present, or what is the problem?
What do you mean? I'm not
Like
maybe I'm not understanding.
when KB test should be done.
Like usually the questions that are found on them is not they don't ask you the when. They will tell you it doesn't matter when. They will tell you usually the question they'll say, okay, the mom we're trying to come up with the measurement of how many liters or how many milliliters of program we have to give, or we're trying to calculate how much we have to give of program to the mom. I think usually it's like after the pregnancy or sometime during the prenatal visit, but they're trying to calculate the point of the questions. We're trying to calculate how much we have to give to the mom. So what's the best test to calculate how much we have to give. That's the usual questions. I never find a question on that that says when to give it. I don't
Oh,
know. Maybe you found it, but I've
okay,
never saw that.
that makes sense now.
Yeah. Rh negative moms are at risk of developing the antibodies if exposed to blood from Rh positive fetus, which most commonly occurs during delivery. If Rhd antigens from the fetal circulation enter the maternal circulation, it's possible that the mom immune system will form antibodies against Rhd antigen. While this carries no significant complication with initial exposure, subsequent pregnancy with Rh positive fetus can result in hemolytic anemia of the newborn as maternal antibodies cause hemolysis of the red blood cells of the fetus when they cross the placenta. ROGAM acts by binding the Rh positive cells that enter the maternal circulation, preventing the immune system from developing the antibodies. Administration of ROGAM is typically performed for Rh negative mom at 28 weeks gestation following delivery of a Rh positive newborn. With following delivery. with any invasive, okay. So 28 weeks gestation following the delivery and with any invasive procedure like amniocentesis and with any episodes of fetal-maternal bleeding. ROGAM is effective for approximately 12 weeks. So even though this patient has received the ROGAM early in pregnancy, enough time has passed that she should receive. Oh, that's a good clue. So it's effective for 12 weeks. That's why you keep giving it. Okay, and it's not E. No further treatment is indicated is inappropriate. Administration of ROGAM is recommended after invasive procedure at 28 weeks and after delivery of the newborn. While this patient received ROGAM early in pregnancy, she should receive it again at 28 weeks in preparation for delivery. If she does not, she's at risk of developing RH immunization. Okay, that's an important thing to remember. So I guess that will help us. If we remember that it's just it's
It should be,
temporary, yeah,
yes.
because it just was for a period of time. It's a short period, I guess, a short period of time. So it will help us remember. Okay, so you have to keep giving it because it only was for a short period of time. Okay.
So we can start giving ROGAM approximately 12 weeks of gestation.
No, no, like what? Okay, maybe I didn't understand your question.
Like this line, immunoglobulin is effective approximately 12 weeks. So even though this patient has received raw immunoglobulin earlier in the pregnancy, enough time to pass that and she should receive an additional dose. She got at 16 weeks, isn't it?
Mm-hmm.
So as she got at 16 weeks, so we can skip, but they told that we should give another dose at 28 weeks. If she do not get at 16 weeks, then we
Mm-hmm.
should give it at 28 weeks must,
Mm-hmm.
isn't it?
Mm-hmm. Mm-hmm.
Like the 28 weeks is the approximate time when ROGAM must be given, but
Mm-hmm.
if somebody get early, so it is not problem. It is helpful. Is it like
Yeah,
that?
yeah, but you only give it early if there is any risk factors like amniocentesis or
So
all
if
that.
any
Yeah. So,
procedure, not in
yeah.
the not in normal case,
No.
like
No. No.
if mom is blood group Rh negative, then we should not.
If she's just RH negative but there is no procedure, then you just give her 28
Okay,
and then after delivery. Yeah. So 28 is where you give any it doesn't matter what you give at 28. Procedure or no procedure, you give at 28 and you give after delivery. Now, if there is procedure, then you can give before, like amniocentesis, whatever, then you can give before, you give at 28 and then you give at delivery.
okay,
Does it make sense? Yeah. Okay. Yeah. Okay, next.
okay. A 15-year-old girl comes to the emergency department because of sudden onset severe pain in the right lower quadrant of the abdomen began 2 hours ago. Her mens started the day before. Her previous mens began six. Her mens started the day before. Her previous mens began 6 weeks ago. Temperature 37.5. There is right adnexal tenderness. Blood count normal. Show normal. Finding beta ECG is negative. Which of the following is the most likely diagnosis? Okay.
Mm, how did you find it so free? Right at nasal tenderness. Blah, blah, blah. Mm, right lower canal abdomen that began 2 hours ago. The day before, previous menses began 6 weeks ago.
If
Mm,
somebody has like right lower quadrant pain and adnexal tenderness after sexual intercourse, like 1 to 2 days after sexual intercourse, what is your diagnosis?
So you think it's rupture ovarian cyst?
Yes, because
Mm,
it is not appendicitis. We
yeah, I know it's not appendicitis, but why is not
why is not?
endometrioma or
Eh,
endometriosis?
sorry,
Why is not endometriosis or endometrioma?
why in endometriosis there is painful menstruation, like dysmenorrhea, the all the D's. There is no D. She has not any painful menstruation or
Okay,
any sort of. And in endometriosis, I think that there is no adnexal tenderness.
okay,
And in endometrioma, there should be mass-like lesion, probably.
master. Okay, get it. You're right. Rupture ovarian cyst. There are multiple subtypes of ovarian cysts, ranging from benign simple cysts to complex malignant cystic masses. Okay. The most common cysts are follicular and corpus luteal hemorrhagic cysts. Follicular cysts are simple cystic structures of the ovary that occur during process of follicle development when an egg is not appropriately released from the follicle during ovulation. Okay. Contrary, a corpus luteum cyst, which can be hemorrhagic, may form following the formation of a mature follicle and subsequent ovulation during the menstrual cycle. Either of these ovarian cysts can potentially rupture, which classically presents with pelvic or lower abdominal pain that is sudden in onset and severe, most commonly after sexual intercourse or other physical activity. Physical exam may show unilateral adnexal mass, which may be tender. Laboratory studies are typically within reference. Pelvic ultrasound will show either a simple or complex cyst ovarian mass or free fluid in the pelvis if it has ruptured, which may include hemorrhagic components, particularly in the setting of corpus luteal hemorrhagic. These are typically managed by observation and supportive therapy. It is not endometrioma. It's a cyst that is formed when ectopic endometrial tissue within the adnesa in a patient with endometriosis. It's a cyst that is formed from ectopic endometrial tissue within the ovary in a patient with endometriosis. If palpable on physical exam, it is often adherent to nearby structures. Endometriosis refers to presence of, outside the uterus and commonly presents with dysmenorrhea dyspnea. This patient has no previous symptom of endometriosis and neither of these conditions present with the acute onset of severe pain. Okay.
Okay. Have you done your breakfast?
Nope.
Okay, you go
Okay.
have your breakfast. Okay.